We'll go ahead and get started. Ann Meerwood is presenting today on baby-friendly step 3, the prenatal education. And I have everybody unmuted right now, so we'll see how we do with any background noise. It seems pretty quiet right now. And y'all can certainly ask questions, or if somebody wants to type a question into the chat box, and we can take questions at the end as well. We are recording this so we can make this available later on for people that couldn't attend today. So Ann, I will hand it over to you.
Okay, great. And you're going to advance the slides, Becky.
Yeah.
You can sort of play it by ear, so go ahead with it. Thank you.
Okay.
So thank you, everybody, for coming on today. Prenatal education, I would say, is probably the most tricky part of the baby-friendly assessment. And go with the slides, Becky, please. We were going to talk about educating women prenatally, a little bit about postpartum, how it carries over into that, some creative strategies, and then I will leave room for discussion and questions at the end. So go ahead, Becky. Just so you have a sense of where we're at with the breastfeeding rates in this country, you know that there's a big disparity, and this is true across all the different states. And there's a lot. I've just put it here on the very big racial categories because Latinos are actually a little higher, Asians are a lot higher, Native Americans, there are a few other groups, but it was a busy slide, so I just put all U.S. black and white because the biggest disparity exists between the black population and the rest of the United States. And the pink dotted line on there, that's actually the poor people line. So if you look at people by socioeconomic status, as well as, you know, as a separate category, you will see that their breastfeeding rate has been low for a very long time and has continued to be low. Next slide. So, you know, the thing that is important to recognize and why that matters in terms of poor people's breastfeeding rates being low and racial minority and the underprivileged groups being low is that prenatal education is a really big deal for women. And you will often hear, when I go around, I will often hear clinicians say things like, well, the woman didn't ask for skin to skin. If you look at the group of people who are not breastfeeding, they are not typically women who are going to say to an obstetrician during the process of being handled prenatally, you need to tell me about skin to skin, or you need to give me skin to skin. So prenatal education is the point where that happens and where the ideas are given to the women. And you need to recognize, that we all need to recognize, that this group of women is not a group that is going to ask for things if we do not empower them to do that. And it may not be because they don't know, it may be because they're too afraid. So they don't have those skills or whatever. So prenatal education is the key. I think you're all very familiar with the baby-friendly hospital initiative. Hopefully most of you are on the way to getting there. It was launched in 1991 by UNICEF and the WHO, and you have to meet the 10 steps. And I am not going to read them all to you, but there needs to be policy, training. Step 3 is what we're talking about today, that pregnant women need the education. And also step 4 plays into that, because as part of the prenatal education, you need to prepare women for the first hour of life and where the baby will be, which will be skin to skin, which is how step 4 is now interpreted. And then if they're separated, you need to keep the moms getting the milk to the babies. It needs to be exclusive breast milk rooming in, which is also something that you may not think of as being a prenatal care issue, but that is something else that you very much need to prepare women for prenatally. You need to prepare them that they know what rooming in is and that that's something that they are looking forward to rather than dreading. And then the other teaching about, you know, not every 3 hours, but on-demand breastfeeding, artificial nipples, and referral afterwards. Most of that needs to actually feature as part of prenatal care as well, so that people come in prepared for these kinds of practices. So we're specifically talking about step 3, which is inform all pregnant women about the benefits of management of breastfeeding. And I have to tell you, I just got hot off this call from a consult call that I did with a hospital in Montana, and it's very fresh in my mind, the prenatal stuff. So I will tell you, they have about 800 births a year, and they have only a small prenatal clinic. But if you have, and there's a big range, some hospitals have no prenatal clinic, and all their patients are coming from private OBs, and some hospitals have no private physicians, and all their patients are coming from something that they're in control of, and then you have everything in between. If you have an OB service that is your hospital, even if it's small, they will go and assess that practice. And how the Baby Friendly USA will assess that practice is they will question 10 women about what their prenatal care was like, and they're going to ask them questions which, if you get to, and when you get to the dissemination phase of the baby-friendly pathway, are all there for you on paper, and they're the audit tools, and they're the same questions that Baby Friendly asks when they come, and they say things to pregnant women like, have you, do you know, can you tell me about skin to skin? Can you tell me about rimming in? Can you tell me about positioning? Can you tell me about the risks of formula, etc., etc.? So the women are expected to know. The only women who are expected to know this are the women who your hospital's clinics treat. So they will not go and ask those questions of a woman whose prenatal care your institution was not directly responsible for. There are pluses and minuses to both things. If you don't have a prenatal clinic, you are off the hook for that part of the assessment, and that is the most difficult part of the assessment to pass, I can promise you. However, you're on the hook because all those women, if you haven't had anyone do the education, your clinics are not doing the education, they're going to come in without knowledge of skin to skin, without knowledge of rooming in, and then you're going to be stuck because you're going to have women who didn't know that you would take the baby back to they won't take the baby back to the nursery, which is what they did with their older 3 children, and you will have women demanding their babies go back in the nursery. So it's a mixed blessing to have or not have prenatal care, but it is very clearly delineated, you know, what kind of care, who is going to be asked the questions, what exactly they're going to be asked, and what they're expected to know, and who's expected to know. Okay, go ahead, Becky. So, as we said, that covers what I was just saying. There's a range of clinical settings. Of course, there are other things. There are WIC offices and, you know, clinics that may not even really be OB clinics, so there are other places that people can pick up their information from. So if you work closely with your WIC office, you can help get some of this education to people by making sure that the WIC office is giving out the same kinds of information you are, and that you're working collaboratively as a team. So, you know, in the olden days, we asked questions like, are you going to breast or bottle feed? And hopefully we've gone away from that model these days. We are not trying, you know, we're not asking this question anymore. We are hopefully giving them an open-ended question, which will tell them, they will be able to give us an informative answer to. So, for example, if you say you're going to breast or bottle feed, and they say bottle feed, you know, and you say that at the first prenatal appointment, well, if you're going to keep asking them that question, you're going to irritate them because they already told you. So it's much better to do the open-ended question, and I do hope that maybe we're at that point where this is something that is not an unusual idea, that people, you know, you say, what have you heard about breastfeeding, or something like that. So that's hopefully the way that we're doing that now. A lot of places, when I speak to them about the need for prenatal education, will say, oh, well, we do a breastfeeding class. Well, those are usually one-time events, unless you're lucky enough to have prenatal group care setting. That would be good. But those are usually one-time events, and they involve like one session of childbirth education or something, and it's only happening once. And so, you know, the people who come to those classes are really not your problem patients. The people who come to those classes are the people who would be probably reading the books and wanting to engage in everything and learn everything and take home all those materials you give them and read them carefully, because they are invested already. So the people who do not have the ability to do that because they're working all day, or they don't have transportation, or they just are not speaking the same language, or whatever, those people are the people you need to outreach to, and those people are not going to come in your breastfeeding class. And I do have to throw in here that, you know, the work that's being done by the COBA and with Danielle and Gafe Dula, that stuff is fabulous, and there's a lot of outreach in your community there. So that's something that is really, you know, worth milking in Oklahoma, because you have great resources there.
No pun intended, huh?
No pun intended. Go ahead, Becky.
Sorry.
So some of the other things that we know from, you know, past lives don't work too well. If you mention breastfeeding once as this idea that maybe they'd like to do, and you can tell this because you ask pregnant women, did anyone talk to you about breastfeeding? And they'll look at you and say, yeah, I think the nurse sort of said something about that the first time I came for my prenatal visit. Well, that isn't going to work. I mean, the research shows that it has to be something that you do repetitively, you talk about repeatedly, and you know it's not just a piece of paper. That doesn't work either. And we do know that people know in general that it's healthier to breastfeed, but actually, you know, women need to know specific benefits, and it would be something they will remember if you tailor it to them. So if you're working with a Native American or a Hispanic population and you talk about diabetes, that's going to ring true for that woman because she's very likely to have a family member or a friend who is who is infected by diabetes. And diabetes is a really great one to talk about because you can kill so many birds with one stone. Diabetes protects the mom. I mean, breastfeeding protects the mom against diabetes. If women breastfeed more, they're less likely to get diabetes. Breastfeeding protects the child against diabetes, type 1 and type 2. So you can actually kill 3 things at once by talking about the protective. You can get 3 benefits for the price of 1 by diabetes. Go ahead.
Sorry. Okay.
So, of course, the minute we start to sort of have these discussions with our prenatal clinicians, whether they be nurses, techs, or doctors, the first thing that we're most likely to hear is, well, we can't spend hours and hours doing detailed counseling. We don't have the time for that. Go ahead. And you know what? That is the concern not just for the clinician, but the patient too. But the clinician is worried that they don't have time to add lots of teaching into the short sessions that they already have. We know that giving them instruction to the patients doesn't work, and hopefully some of the clinicians have picked up on that. You know, they give them a brochure and it's in the bin before they get out the door. So written instruction of in itself doesn't work. Moms need to know what to expect, and the clinicians are concerned that they're not going to have that. And we, as a hospital base, we need the moms to come in prepared. Next slide. The patients don't want actually all that stuff either. They do not want to sit there listening to 30 minutes on breastfeeding. They don't want to read a 50-page handout, and they don't want to only hear it at the beginning of the pregnancy, and then 9 months later be supposed to remember something. And we all know that pregnant and new moms don't remember things very well in detail about like what they're being told at a given moment if they may be being distracted by something else, and especially if they just came in and they just had a positive pregnancy test. They're not going to remember all the stuff that you tell them about some breastfeeding thing that's not going to happen, that they even didn't know they were going to have a baby, and they're certainly not visualizing breastfeeding anything real right now 9 months down the road. So giving them that information at the beginning really doesn't help. So actually you should take this as a positive. The patient's kind of on the same page with you. They don't really want the kind of education you're worrying about giving them anyway. So what do we know? So this picture brings to mind what? Well, you're all on mute, so I'll tell you. But it doesn't bring to mind necessarily horses. For those of you who Americans watch the Super Bowl or watch sports or watch ads, this brings to mind Budweiser. I don't think it says on there anything about Budweiser, but that picture means Budweiser beer, right? Those are the Budweiser horses. Very clever advertising. We don't show the product in the advert at all. We also know that patients, based on our medical evidence, remember short, repeated bursts of things. We know that as providers and clinicians, we can capitalize on teachable moments. There's a moment when a woman is very prepared to hear some piece of information. You know, if you just got diagnosed with some horrible disease, that is a teachable moment to tell somebody how to help themselves with this disease. If you tell them about, you know, this is how you treat cancer, but they're not involved and it doesn't have anything to do with them, it's not a teachable moment because it's not important information to them right then. But there is a moment for all of these different things that it's going to be more teachable than others, and we need to capitalize on that. We also know that doctors in particular have a very powerful influence on people, and we should never underestimate that. So a few short words from a doctor is worth a great deal of time from someone who like me, might not be a doctor. So doctors are very powerful, and a few words from them can make a big difference. We also know that huge corporations spend an absolute ton of money on advertising, and most Super Bowl viewers actually watch for the ads, which I think is a very sad thing for you Americans with your sports, but that's the case. So more people watch the Super Bowl for the ads. So people actually like ads. So there is a way to get information across to people that they want, and in a way that they can actually enjoy. Next slide. I fly all the time. I don't know how many of you fly frequently, but I would like to thank Delta Airlines for the best commercials I have ever seen. in terms of promoting the most boring thing I have ever seen, which is how to fasten a seatbelt. So if you fly, like I do, almost every week, you have gone through this education video 10,000 billion times, and you know how to fasten your seatbelt, and you know that you have to find out where the exits are, and it's extremely challenging for the airlines to put across that public health message. And there are other messages out there like that, like, fasten your seatbelt in the car, or, quit. There are other things that are very, very hard to promote because they're no fun and they're not interesting. The Delta Airlines commercial is absolutely brilliant, and I will just say it's sublime. I mean, this one, for example, the one on the top left of your screen there, this is the one that says if you're sitting in an exit row, you need to tell the air steward if you can perform the tasks. And these three guys, who are all identical, they're like triplets, or they're the same person, they wear the same clothes, they all look at each other and they all stand up and shake their heads and walk away. And then if you look at the one below, this is something to do with, like, fasten your seatbelt. But, the people behind have all this huge hair. So they're actually gluing you to these screens. I mean, every time I watch this ad, like, for example, there's another fasten seatbelt bit where there's this huge butch guy, and when it shows the person fastening the seatbelt, they've got perfectly manicured nails. And I only picked that up last week. So they have this off to a T, and they are extremely creative, and they're spending a fortune doing this to get you to watch a boring ad. So think creatively. Next slide. So here's another bit of interesting, creative, extraneous information. I used to be a journalist, and when we were journalists 20 years ago, and I don't know if they do this anymore with television the way it is now, but the way we measured news scripts was to write 3 words a page, a sentence on a page, a line on a page. So if you look at that, you write that piece of news, because when you're writing the news, you have to make it hit the picture. So, you're saying, President Obama did this. When you're reading that, you need the person to be seeing President Obama on the screen. If you say President Obama got a new dog, you need to know how many seconds into your script the dog shows up on the screen. So you write them like this so that you can actually count down. So like 6 seconds, we hit shots. So we might be showing a picture of the shot, whatever it is. So that is how you work it. That's how you do it. So there are 3 words per second when you write a news script. Next slide. Ads are much faster since time, money, round, salary, bank commercials are read more quickly. There are more words per second, and that's all that garbage you get at the end of the radio ad that you don't listen to because they're paying for time and they cram it all in. But there would be more than 3 words per second in an ad on the radio because they need to fit more stuff in, and anything that's extraneous they read really fast so you don't even hear it. So how are you going to translate this into practice? Well, we have some things that we need to teach prenatally. We need to teach the specific benefits of breastfeeding, and I like, actually, Kim Bog came up with this, and I like it, the importance of breastfeeding rather than the benefits of breastfeeding. It still puts it in a positive light, but it doesn't talk about benefits and its importance, and I like to think of that. The risks of formula feeding. You have to teach your prenatal patients the risks of formula feeding, whether you like it or not. If you're going to be baby friendly, they will ask them about the risks of formula feeding, and that is not going to be something that's an easy sell to your clinicians, but you're going to have to do that. You're going to have to teach them about skin to skin, rooming in, and positioning and latch, and some other stuff. So how long is that going to take you? So when you talk to these doctors, right, they're going to say, oh my goodness, how can I add, 2 hours worth of information to my current schedule? So here is the benefits of breastfeeding. We get 4 benefits here in 7.5 seconds. So think back to 3 words per second, okay? Breastfeeding can prevent diabetes in the baby and in mom. Breastfeeding helps mom lose pregnancy weight more quickly. Breastfeeding boosts baby's IQ. That took 7.5 seconds, and you fitted in 4 benefits because you got 2 for 1 in the first one because you talked about both the baby and the mom. And if you're going to tell me that that is more effectively presented as a 16-page handout, I can say you're wrong. I can say they may not remember this the first time that you say it. But if you devote 7.5 seconds to every prenatal appointment and you say this, they will remember it because we know that repeated things, it sticks in. This is something that you can teach early in pregnancy when they're thinking about how to feed their babies, and it's a more sort of generic point, but you can repeat it during the different phases as it becomes a more real thing. Now, here's the tricky one. Did anyone talk to you about the risks of formula feeding? they will ask your patients this, okay, and the answer is usually no. And that puts me, when I'm doing these assessments, which I do fairly often, into a position where I'm having to teach, because I have to say, when I do the postpartum assessments, I just sort of report out to the hospitals, mom's got this or they didn't get that. But it's beyond me to sit down with a pregnant lady, even if I'm just doing an assessment, and not teach her something that she should have been taught. But it doesn't take very long. So if she says, no one's taught me about the risks of formula feeding, I will say, if you feed formula too soon, it will undermine your milk supply. You'll make less milk if you give formula. And that whole thing takes 12 seconds, including the question. And that's a fairly benign risk of formula feeding, and it may not be one that we jump to in our panic of thinking, oh, we have to talk about the risk of formula feeding, we're going to make everyone feel guilty, we're going to make them think they're going to kill their babies. Well, you know, milk supply is one of the risks of formula feeding. You will undermine your milk supply, and everyone's heard about not having enough milk. So that's a really good one to include. Next slide. Another thing about risks of formula feeding that you can give is giving formula early on can mess up the baby's immune system too. If you have a family history of diabetes, early formula can make the baby more likely to get diabetes. And that took another 11 seconds, which is 23 seconds total. So we have covered that, and again, it's something that you can teach early in pregnancy, and you can repeat it later on. Skin to skin in 20 seconds. Okay, so remember we said that doctors are very powerful people, okay? If your OB does this with a woman, I would be very surprised if she forgets this. The doctor, she says, I'm your doctor. I or one of my group will be there when your baby's born. We will put your baby skin to skin on your bare chest with just a diaper and a hat as soon as she is born. That's it. Skin to skin in 14 seconds. If you really want to give them the whole caboodle, you can add, this will keep your baby warm, keep her blood sugar up, and help with breastfeeding and give you great bonding time. And that's it. 20 seconds. You're done. Repeat it a few times, you'll get the message across. Next slide. Teachable moment, you can mention it earlier if you've an extra 20 seconds in the appointment process, but you know, skin to skin and birth, when our bellies start to get big and we start to wonder how on earth we're going to get that baby out, that's when people are started to focus on the, you know, the pragmatic, practical, oh my goodness, what's going to happen to me in 4, 5, 6 weeks from now? And that's a good time to talk about skin to skin, because they're really thinking concretely about the birth and what the process is and what's going to happen. So that's a really good time, and it's a nice distracting thing in a way. I mean, yes, you're going to go through all the pain of labor, but you know what your reward's going to be? We're going to put the baby right there on you, and you and the baby will have some great time together, and you'll be able to keep the baby warm, and you won't need anyone to interfere. It'll just be you and Dad watching, or whoever else is with you watching. Rooming in. This is very badly taught prenatally, and so one of the things that, you know, we've fine-tuned is how we're going to talk to this about people. So this is a huge one, guys, in terms of how it is presented. So I'll read you this one so you're not distracted by the screen, but then tell you some of the bad news. So the way that I would advise you to do it, and this is what I do, I look the mom in the eye and I say, at this hospital, we make sure moms and babies stay together all the time. Nobody should take your baby away. It's your baby. And then I say, and don't let them. I use 3 extra seconds. And then if it's a hospital that I'm fed up with, I'll say, and you know what, you're going to be the test case for this because they're supposed to be doing this and they're not. So don't let them at all. Don't let them take the baby out. They're not supposed to. They can do the stuff in the room. It is completely different when obstetricians, which is, I'm just quoting you actual examples, an obstetrician will come in and they will say to the mom prenatally, Hospital X is closing the nursery. You need to make sure that you have a spot reserved in that nursery. And you know what? Here's my cell phone number, and you can phone me up if they say they won't put the baby in the nursery, and I'll tell them to do it for you. And that's an actual example of one hospital that I'm working with. So, you know, it's the same information. It's rooming in information, but, you know, it's being presented in polar opposite ways. And you know, you may have some moms that don't want the baby with them. They may have 4 children at home and they just want to put that baby in the nursery at night, and you will have some like that. But if you present it like this, in 8 seconds, prenatally, and you look the mom in the eye and say, don't let them take that baby away, you've presented a completely different vision and version of rooming in than most people think about when we talk about rooming in. Next slide.
Hey, Anne.
Yeah.
I can comment on that one. I think that I agree with you. I think that is a very powerful one of the steps to make sure moms know about, and particularly when you're looking at the disparities and you look at the African American community or the Native American community where they have a history of babies being taken away from other people in their family. So they're already worried about that, and they want to hear that they want to be empowered, and they want to hear that it's your baby and no one should take your baby away from
Right.
you.
Absolutely. So. Yeah. So positioning and latches is a little bit different. This might take you a few more seconds because I really strongly suggest that you have a doll and a breast available in the rooms, in the prenatal rooms. That will be a visual cue to the clinician to remember to do the breast, to help mom with the breastfeeding teaching. That will be the clue. So hopefully they'll do that. I'm amazed how many prenatal clinics we go to that they don't have any kind of equipment like that around, which is kind of just really interesting to me. I mean, they don't have it. It's interesting. And then if you don't have time to do that, you can put pictures on the walls. And if you really just want to make a really big impression, you say if the baby doesn't latch well, it's really going to hurt. And I don't think mom's going to forget that. So, there are different ways to do positioning. It may take a little bit longer, but you can back it up with visuals on the wall. But positioning and latch is something, and you probably don't need to keep repeating that. I mean, once the mom's shown you, like what you're showing them on the positioning, that's, if you're doing it, if you're putting the time in to do it practically and manually, that kind of memory will stay with her. She's going to remember that, this is how I held that baby doll when I was doing that. You don't need to do that every single time. Next slide. So how long did all that prenatal fast food advertising take? Next slide, because I can't remember.
Oh, sorry. Oops.
Oh, there you go. 63 seconds. 63 seconds. Okay? And, I'm not making this up, guys. I believe in this. This is not a trick. This is what advertisers do to us. This is how we have to think about this in new terms, in terms that will appeal to the patients and all that stuff. So 63 seconds, all of that will take if you ran it from A to Z all the way through in one go. So, of course, we don't just want to rely on talking. There are multiple strategies we can use. Go ahead. So this is not just there for the picture, but this is there for, I want to tell you a little bit of information about this. So there's a big hospital system in Detroit that is going baby friendly, and one of them is already baby friendly. They were part of the Best at Beginnings project, and they had a really big problem in their prenatal clinic. I think the next slide is also relevant, Becky. Yeah. So they were doing their audits, and they were not getting through. They were not getting the message across. It wasn't working. So they basically said that they needed to put some posters up in the prenatal clinics, but they went several steps further than that, because what they had been trying to do, and they'd already worked on this quite hard, and they had a nice table there with an IBCLC lactation consultant sitting behind the table, and it said, like, ask me about breastfeeding right there in the waiting room, and no one asked. No one came up to the table. So they said, okay, forget that. So they replaced the IBCLC in that situation with peer counselors who just went into the clinic and sat down next to people and didn't say, come to the table. They just basically sat down and said, oh, I can see you're pregnant. Has anyone talked to you about breastfeeding? And then they had these posters. So there was this, they came up with like a different poster every month or something like that. And then they had a competition. So they said to the mom, okay, here's 3 different posters. Can you look at these posters, and then you vote on a piece of paper on which of these posters you would like, you think is the best, and we'll put your name in a hat, and they drew a prize at the end of every month. So they did that. Now the point was, I mean, they did get a prize, and they followed through and everything. But the point was, yeah, you can go to the next slide, Becky. Mm-hmm. They go to the next slide. They had to actually look at the posters. Like, they had to read the posters in order to be able to vote on them, and that was the whole point. So you can see that was a very detailed process in order to be able to get the posters viewed and evaluated and read and digested by the moms. But, it wasn't very expensive, and it wasn't very complicated. It was a lovely idea once they got down to it. And I'm just showing you some more creative things, though. When we were on Navajo Nation, we did this rooming in campaign, and this was the original rooming in, and this is a Navajo Hogan, the traditional house of the Navajo, where everybody did everything in one room. They all live in one room. And this was what we came up with for them when we were there, actually, with a native healer, and we came up with this idea to do a very relevant, culturally relevant rooming in poster. And this is actually taken from a hospital that I was working with, just like they had some of these visuals I'm just giving you. This was about hand expression, and they had this up on the wall showing how women hand express, and this is one of the Native American hospitals, so, you know, people might say to me, oh, this is too modest for our setting. Well, the Native Americans actually are fairly modest, but this was used in their hospital. It's fairly clinical. You know, it's a clinical picture of how to express milk. So, as we were saying at the beginning, if you do these kind of preparations, if you set it up like this, then women should be prepared for skin-to-skin when they arrive in labor. They should know about rooming in, how that has been described to them, and what, you know, depending on what they've been told, is what they'll put out there will influence the way that they feel about it. It also encourages your hospital delivery service, because if somebody's been out there telling them you're going to get skin to skin, that's what they expect. And that's, if they have got the empowerment to speak to the provider about that, they will ask for it. You know, you really hope that they do, but even if they don't, they might complain that they didn't get it later on. So especially if you're doing your audit tools and you're asking people what kind of care they got. So you're going to have a population that's going to perpetuate these kinds of processes in the hospital, because they're going to come in asking for them, and they're going to be advocating for optimal MCH care. Next slide. In terms of postpartum, and we're talking about the immediate postpartum, I just think that, you know, we should never forget or underestimate the impact that that short period of a woman's life has on the rest of their life. And those of you who have had children or have been present with other family members when they've had young children, you will remember as a new mother everything about that for the rest of your life. And the clinician, you know, we see these sort of factories of people going through, and we, you know, it's embarrassing sometimes, because 2 years later someone will come up to us and say, oh, you know, thank you so much for what you did, and you can't remember who this person is, but they will remember you, and they will remember everything about it. And it's like our own teachable moments that may not be connected to prenatal, but to be connected to, you know, when JFK was shot, or if some of us are too young for that, you know, what happened when the Twin Towers fell in Oklahoma, where were you when the bomb went off? Those, you don't remember just the event. You remember all the little details that happened, that, you know, within maybe the hour after this critical event happened. You remember those forever, and they're not the kinds of details that you would remember anywhere else. Next page. Oh, actually, I think I've got this, but I'm going to written, but I'm going to say it anyway. You know, so I remember, like, the name of the nurse that talked to me. I remember what she said to me. I remember that whether she said I was, you know, if I was good at something, I was really excited. Or you're bonding well. The bonding's going well. She was writing the chart, and I thought, oh, good, you know, I passed that test. I remember, like, the name of the child of the nurse that delivered my baby, because it was the same as one of my children. I remember absolutely everything about that person, and other people remember things like the clothing they were wearing, the jewelry they were wearing. They will remember every word you say to them, and you are one long teachable moment. So make it good. Make it good, because they are not going to forget that. In terms of getting the clinicians themselves on board, you will see that that previous slide was a nurse, and this is a physician. And they, in this is one of your hospitals, actually, in Oklahoma. This is Cherokee, who are set up for an assessment fairly soon, and they were very clever, and they, you know, made all their doctors into breastfeeding advocates, whether they liked it or not, basically, because they bought them all these white coats with a baby on the sleeve. So all their doctors are by default breastfeeding advocates when they go into the patient's room. Training is a big deal. This was a great sport doctor. I don't think this is an Oklahoma picture, but this is one of the hospitals, I think it's somewhere in Virginia. And, you know, hand expression is one of the big problems to get providers to learn. And this doctor very nicely agreed to be on the front of their provider baby education poster doing hand expression, or their booklet, actually. So that kind of was a nice visual cue that he agreed to be on there. So these are just some of the other ways that you can kind of promote the training and the visuals. So this is what I was going to say. You know, make it good, because you've got the power to help them. I mean, we've seen that. There's this whole, you know, fear is a life course and everything, and there are points in people's lives where, if you think of it as a sort of bent stick, and and the stick's going in a certain direction, and then it bends, and the rest of the stick's also straight, but it's somehow changed direction at the point where it bends. And some of these moments like birth are the places where these bends can occur. And if you bend that stick down and you give them a bad birth experience and a bad time in the hospital, that could continue as a downward spiral. And if you bend that stick up, they will continue on a higher up straight line, and you have the power to do that. And you will influence them going forward. And, you know, through the work I've done with Native Americans, many of the tribes believe you will not only heal the future, but you will heal the past. And that's not just a tribal belief, but that speaks to our own knowledge of historical trauma and parenting and psychology, and that we know that, you know, it can be something that's a very healing time. So I would say that, you know, all of this is actually all to the same point, which is that these short, simple, true messages, however you present them, and you need to present them in an out-of-the-box way, both prenatally and at the time of birth, are really important and need to be thought about carefully in the same way that Budweiser and Delta and all those places think about them. The community is another really important part of this. Cami in this picture is the person that came to Oklahoma, and you know, this part of the learning for me really came true when I was in one of the hospitals, and we had doctors saying those women don't want to breastfeed, and I said, well, I think these women do want to breastfeed, and we brought some community members in to talk about the efforts in the doctor meeting about what the community was doing to actually have them there in the same place. And these are the people who will remember you for the rest of your life, doctor, and they actually might remember you, and they may point at you and they may say, oh, you delivered my last baby, and the doctor will freak out because they won't remember what they did. And that puts it on a much more personal level. It avoids the clinicians putting them all together in a big bunch and saying these women don't want to breastfeed, and it uses an emotive approach as well as data-driven to get through to the healthcare professionals. And go to the, okay, so just a couple of quick things to finish up with the Native American stuff. I just like some of these slides. This is a small hospital out in Zuni where they did some really great work with outreach into the community. And just so you know, this is a tiny hospital, but the building on the right-hand side there, that's actually a diabetes clinic, and that's the same size as the hospital. So they have a huge problem with you know, diabetes and things. And so it's a big issue in their community, breastfeeding. And this is the WIC office at Zuni, and the picture at the bottom is actually what if you stand at the door of that WIC office and look out towards across the street, that is what you see. And I went into this WIC office. Next slide, please. And the lady on the left here, Ruby Wolf, whom some of you in Oklahoma know, I think, because she comes to the national WIC meetings. When I met her in that office, she stepped up and she said, my name is Ruby Wolf, and I'm here to put the infant formula industry out of business. And that was just great. And she is in there with one of the public health nurses. So this woman actually works in the hospital, and she works in the hospital with Ruby and her connect. So she's a public health nurse. She goes out into the community, but Ruby also helps to liaise that so that they work together as a WIC office and a community health nursing to pick up problem patients. Next slide. And that is a wall of pictures of all the patients that breastfeed. And these are their peer counselors. They have Zuni WIC peer counselors. Some of you have peer counselors through your WIC offices. I strongly encourage you, as part of your prenatal and postpartum outreach, to get in touch with your peer counselors and get in your WIC programs. And some of the ways that you can get WIC working, you know, in the community, in the prenatal and postpartum setting. Usually we connect through WIC through pumps, because suddenly we need a pump. But there are other ways that the peer counselors can interact, like I was telling you about the hospital in Detroit, where they're going to the prenatal clinic. You can have peers in the hospitals. If there's an agreement in place, you can have training materials that they share with you. Get them onto your task forces. Forget the last line. That's from the presentation. Sorry. Keep going. These ones are not relevant. I'm sorry. Just click for this. So, you know, I think I will end by saying that baby friendly matters because it embodies healthy and compassionate and best practice care. And we come to this to try and pass a test. But we're not really here to pass a test. We're here to promote and ensure that the best form of care happens. And babies and women have the right to be together, and the babies have the right to receive human milk. And it's not a test, it's a standard of care for a reason. And last slide. This is a community I work with in northern Montana. They have some indescribably terrible social problems in this community. It's a small hospital, hundreds of miles from any major facilities, over 100 miles from any major facilities. And they have a 44% rate of exclusive breastfeeding in this hospital, despite all the traumas and the illnesses and the sick people that deliver there, and about a 90% initiation rate. And they became baby-friendly last year. And I am telling you that if a hospital like this in the northernmost reaches of Montana can do this, then hospitals all over the country can do this, and that all the things that we're talking about really should come to fruition, and you should look at this as something that you can do rather than a barrier. And that's it. Thank you.
Well, thank you very much, Anne. I think I've got, okay, let me see, make sure if I can unmute. Somehow that's not, no, I think everybody's actually unmuted. So if anyone has any questions for Anne, I hadn't seen anything in the show up in the chat box, though I'm not sure if I'm quite reading it right. But does anybody have any questions for Anne? Can anybody say anything? Ingrid, we can still hear you, right?
I'm sorry. Oh, yeah. Sorry,
I'm not seeing the chat. I don't know if there's anything in the chat box, but I'm not. Actually, I can look and see if I can see it.
Yeah, I don't see anything in the chat box, so I'm just trying to see who I've got on there. I know Nancy's on. Nancy, can you just make sure? It looks like I have everybody unmuted. So
I just typed a test message in the chat box.
Oh, I see it. Okay, great. Thanks. Yeah, it's a new format, so I'm not as familiar with it. But as we see if we have any questions from anyone, just to also make sure people are aware that the 15th annual WIC breastfeeding symposium is rapidly approaching on Friday, June 12th, and it will be at UCO in Edmond, and we have a great lineup of speakers this year. We've got the pair of occupational therapists and IBCLCs who work at a children's hospital in Seattle, Wolf and Glass, who will be talking about some breastfeeding challenges and oral anomalies and so forth. Clifton Keenan, who some of you we've had him here for one of our summits, and he was here for A1, so he's giving a couple presentations. And then we will actually be doing something new in sharing, kind of having some panel presentations with a number of different Oklahoma resources, people representing different organizations that have other community support or resources for breastfeeding families. So like 5 minutes. And so there's, 10 or 12 different organizations that will be presenting on that. So, Nancy said she just tried to say hi. I wonder, because it says it's not muted. Oh well, so if anyone does.
Is anyone else trying to speak?
Yeah, I know. Or wants to type into
the chat, guys, if you're trying to speak and you can't.
Or if anybody has any other questions. Ingrid, I can't think of any other announcements right now. Can you?
No, the WIC conference is the only thing I can think of, which you mentioned.
Okay.
So, Dan, I have a question as far as prenatal, like in the clinics.
Yeah.
So do you have like these little scripting things, like, you can, after birth, we'll put the baby on your belly. Do you have a standard way of getting people to do this, or how do they incorporate that day to day?
Okay, so as part of Baby Friendly, you need to come up with like a prenatal curriculum. And that is something that you start to work on fairly early in the baby-friendly process. So you need to say, okay, this is how we're going to teach prenatal education, and this is when we're going to teach these different things. The proof of the pudding is when the mother answers a question, okay? So if a mom, can't answer the question, then it doesn't really matter what your prenatal curriculum said, because if she hasn't been taught, she hasn't been taught. But, they will look at your curriculum as well. So the content of the curriculum needs to cover everything that's going to come up on the questions. The way in which you cover that, as long as you don't have like non-baby friendly compliant materials, like you don't have anything about, you know, how to feed formula in prenatal care, as long as it's compliant, they're not going to say, oh, we don't think you taught them the right way. So if you say we think this scripting is going to be the best way to teach this, and we teach skin, you've got to finish by 32 weeks per baby friendly. The curriculum, that doesn't mean you can't review, but your initial curriculum needs to be done by 32 weeks. So if you say, okay, you know, at 30 weeks we teach skin to skin, and this is the brochure we give them, or this is the scripting we use, that will be okay for baby friendly. But they need to know, like, what your plan is. I mean, it shouldn't be just like haphazard. Oh, let's talk about skin to skin, Mrs. Jones, today. I mean, you need to have a curriculum.
Right. I guess my question was, like, do you have people like saying, okay, at the 28-week visit, we're gonna make sure that when the nurse is reviewing the patient, that they say, you know, how long are you planning on breastfeeding?
Well, it needs to be in your curriculum. I mean, that's what you need to have in the curriculum. If it says in the curriculum we'll do that at 28 weeks, then you make sure it's done. I mean, you wouldn't just say, I'm not quite sure I understand the. If you've got
no, I guess I'm asking for like an example. Like some clinics have done it this way, that they have it at 28 weeks. You discuss this, and this visit.
Well, they split it up. I mean, you need to split up your education, because you can't. I mean, unless you really just do this 60 seconds every time they come in, and you find it works fine. But you know, you can't do all your education in one go. So you need to have it split up by trimester and by weeks, and in the chart and checked off, so that, okay, at 6 weeks we give them this, at 8 weeks we give them that, at 2 months we give them that. And it doesn't, I mean, I gave you some pointers during the talk to what you might think of doing when. But they're not going to say, oh, you can't do X at week X. I mean, you can come up with whatever you want. They're going to say, did the patient learn it?
Mm-hmm.
Right.
So has anyone that you know of taken what you've given here and incorporated it into using your specific examples?
No, I have to say that I have not tested this, okay? It's not being published. I mean, unfortunately, there's very little published to show what does work. There's quite a lot published to show what doesn't work, and it's quite difficult, and to do it. And it would be lovely to test this out. And I can't say to you this is evidence-based. This is just my suggestion to get through that big barrier of, we know if we give them loads and loads of education, they won't read it, and we know it doesn't work, and we know that our doctors are telling us that they don't have time to do that. Well, here's a suggestion. And if you guys want to test it out, that's great. Because I can tell you that some of these things, in individual circumstances, yes, they have worked. So, for example, talking to them about those posters, those scores went up. Doing the thing that we talked about at the hospital, where they had that they had a system where people, you looked at certain things, whatever it is. These things that solutions that we've engineered to fit specific hospitals, of which examples I've given you, have worked, because those hospitals have become baby friendly, and we needed to bring in a solution because whatever they were doing before wasn't working. But is there a big randomized trial out there to show this works? No, there's not. But these have been implemented solutions that have worked in individual circumstances when something else wasn't working first.
Right. Well, that's a great point.
Yeah, and that's what I was going to say, too, that I think an individual hospital that tries to implement this as an example of, another approach to getting the prenatal education accomplished, it's going to show up in your audits as you do your patient audits and interview the mothers in the hospital after you've been doing this for a bit. And if they can answer the questions, then that approach is working better than what was tried previously. So
right.
That's ultimately the goal.
Yeah.
So, all right. Any other questions? It might be that people don't, have a headset or something. I know Nancy said she can hear us, but she couldn't say anything. She didn't have a microphone. So, if anybody.
This is Evelyn. Can you hear me?
Yeah.
Yes, I can hear you.
Hey, I was just curious. It's really not on this particular topic, but we've been trying for several weeks now to get Baby Friendly to respond to us so that we can move into phase 4. And still having some problems, and I don't know if there's been a holdup there, but I just was curious to see if Ann knew of anything that would kind of hold them up from getting back to us.
Well, sometimes there's a lag time. What is it you're trying to find out?
Well, I've been waiting on an invoice so I could pay for my fee for the next phase. And
well, just keep bugging them. Just bug them and bug them and bug them. I think they've got some new people there recently. I was told that there's some new people there. I don't know what's happened. I can't really comment on that, but I would just keep bugging them.
I didn't know if you knew of anything going on. It might like there was a whole bunch of hospitals that were applying, and maybe I don't
know of anything like that. I don't know of anything like that.
Okay.
Well, and Evelyn and
we just are wanting to get it going, and
it's
kind of on hold right now. So.
Exactly. I've just gotten a new contact at Baby Friendly USA that I'm going to get hold of. So, so I'm gonna ask her for some help on that. So.
Okay, that would be great.
So I've got and I'll copy you on that email.
Okay, that'd be great. Thank you.
We'll see what we can do there. So.
Yeah.
All right. Anybody else have any other questions? Even something not related to our topic today. Happy to answer. I know one, Ingrid, I'm going to just share, we had done the survey of our participating hospitals just to get some feedback from y'all about the different aspects of our state project and what's been working, what else would make it better. And there were some requests for a listserv or some way for the participating hospitals to be able to communicate securely by email. So we're actually looking into that to see if we can get something set up so you'll have a good way to do that and be able to ask different questions too. So.
And what I'm working on is we're trying to make it like a secure web forum where you could go and like log in and post a question, and then other hospitals can post back like getting rid of pacifiers. This is what we did. But the challenge, we're still working out the kinks because we want to make it secure so that you guys can ask whatever questions you want to ask without being concerned that it's viewable by the public. And so we're working on finding a way that OU Health Sciences Center can host it, but you don't have to have an OU log on. And so
that's where that is. Yeah.
Yeah. Once we get it clear, something set up, we'll make that happen.
Great.
We'll make you all aware of how to access it.
All right. Well, I think that's all. Ingrid, what's our I should know what our next topic is for next month. Do you remember?
That's step 5 and 6, which is Oklahoma Mother's Milk Bank. It's going to be maintaining lactation when separated and medical indication for supplementation. So.
Okay. All right. Well, I think unless we have any other further questions, we will let everybody go. Stay safe and weather aware at this time of year. We are getting lots of rain out there today. And thanks for everybody for joining us. And thanks to Ann for presenting today. That was really good information. So
thank you all.
All right.
Take care.
Thank y'all.
Bye-bye.
Bye-bye.
Bye-bye.